Good afternoon, everyone, and welcome to our next Safer Prescribing Series webinar funded by the Michigan Department of Health and Human Services. Today, we will be discussing nursing and opioids, providing pain care and preventing overdose. My name is Mike Smith. I'm an associate professor at the University of Michigan in the College of Pharmacy. And today we have two wonderful speakers that you'll hear from shortly. We just have a few slides to go through before we get to them. Next. There are no financial disclosures for this presentation. Next slide. On the screen, you will see the learning objectives for today's sessions. We will hear from both of our speakers and have time for question and answer at the end of the session. Please put any questions that you have in the Q&A and the Zoom controls at any time during the session. Next slide. We are offering 1.5 AMA PRA Category 1 credits for free for attending the session. You will find this information for claiming CME at the end of the session and in follow-up email you'll receive later today. Next slide. So now for our speakers. First, Elizabeth or Liz Habercorn is a clinical assistant professor at the University of Michigan School of Nursing and a board-certified family nurse practitioner in Metro Detroit. She earned her DNP and MSN from the University of Michigan and her BSN from Madonna University. As a clinician educator and substance use disorder specialist, Dr. Habercorn's work focuses on addiction treatment, medications for substance use disorder, harm reduction, and reducing stigma. She brings her frontline clinical experience into the classroom, preparing nurses to provide compassionate, evidence-based care to individuals and communities affected by substance use. Her scholarship focuses on community health, implementation science, and vulnerable populations, with recent work examining peer recovery coaches and continuity of care for individuals with opioid use disorder, transitioning from incarceration to the community. She is active in nursing and addiction-focused professional organizations and has been recognized for excellence in teaching and mentorship, including the University of Michigan School of Nursing's 2023-2024 Preceptor of the Year Award. Our second speaker today is Deb Russell. She's a nurse practitioner at the Ohio State Medical Center who focuses on palliative care, harm reduction, and supporting clinicians in safe, equitable opioid-related care. Her work centers on helping teams provide effective pain management and practical overdose prevention strategies. She has presented at national conferences and published articles on a variety of topics related to palliative care and substance use. She's a member of the Ohio State University Cancer Institutional Review Board and the Hospice and Palliative Nurses Association, American Association of Nurse Practitioners. I'll hand it over to Liz to begin our presentation.
Pleasure to be here. Deb and I thought that the best way to present this information is through a case. So that's where we're going to start today. So first, let's talk about our patient and kind of some background on her. We're going to be talking about Angela here. And in her 20s, she got into a car accident. She had some lumbar disc issues, chronic mid, lower back pain. And before that accident, she had some recreational opioid and stimulant use. No major consequences from that had occurred. Before the car accident, Angela had a rough childhood behind her. And after the accident, she was prescribed opioids for post-accident pain with some rapid escalation. She cycled through 2 different pain management clinics throughout the years. She was tapered, discharged for non-compliant behavior, some early refill requests, unexpected urine drug screen as she struggled through her opioid use disorder as well. Prescriptions were stopped. She went through withdrawal, unmanaged pain. She started with heroin use and eventually progressed from intranasal to injection use within months. So this is where she really had some chaotic years. She had recurrent ER visits for cellulitis and withdrawal, some brief hospital stays, 3 stints in a detox and rehab facilities. None of them really held. And in the background, while all of this is going on, her parents are informally raising her 2 kids during these worst periods. Her relationship are strained across the board. About 2 years ago, she was referred to my clinic after an ER visit for an injection site abscess. Long and short, we started her on buprenorphine, and she's been sober from illicit opioids since then. And I have to say, her first year, she was sober but unstable. She had spotty appointment attendance. She had significant barriers, including transportation, no reliable car, kids' school schedules, babysitting issues, housing insecurities. She had no-shows, reschedules, gaps in care. And really, we want to talk about, too, this nurse care manager role of the clinic, where outreach, care coordination, and barrier problem solving was really what kept her in treatment. And we didn't treat her as something like non-compliance. So this is our patient now and today. She's been stable on buprenorphine for about 2 years. She's employed at a physically demanding job, something like waitressing. She has stable housing, and she's back with both of her kids. Her parents have kind of shifted from that custodial to supportive role. And this is really her first sustained engagement in healthcare as an adult on the buprenorphine, but still dealing with chronic pain as well. Next slide, please. So let's stop and talk a little bit about pain and opioid use disorder and how those two can feed each other. Chronic pain is defined as pain lasting more than 3 months. It's persisting past normal tissue healing. It affects about 20% of US adults, and about 6% have high impact chronic pain that really limits their daily function. Angela's in that 20%. Her back pain from the initial car accident never resolved fully into healed. And now she's in a physically demanding a job that's kind of making it worse, if not better. She also has opioid use disorder, and 45% of patients receiving medication for opioid use disorder also live with co-occurring pain. Again, she's in that 45%. It's also worth mentioning that among people on long-term therapy, opioid therapy, 8 to 12% develop an opioid use disorder. So these really aren't two patient populations. They're largely one population with two separate systems that are built around them. Angela obviously lived in that split for a number of years. She had pain clinics discharge her when her use became non-compliant. She had EDs treating abscesses, but not perhaps the addiction. And detox programs addressed the opioid use disorder, but not the pain that was driving it. So this leads to the introduction of something called the reciprocal model. Pain drives that substance abuse, and the substance relieves that pain short term, but the substance use worsens the pain over time via withdrawal and opioid-induced hyperalgesia. So we've got this feedback loop. And this is Angela's the 3 detox pattern that we see. Each stint treated addiction in isolation. She returned to unmanaged pain, and pain pulled her back into use. To create a really good care plan, we can't treat these two problems as one, or rather as two separate issues, but we have to understand how they intersect within this person and build that care plan from that. For Angela, her chronic pain and opioid use disorder were never separate. They really fed each other. And it's worth mentioning, we do have an access problem. Patients who disclose opioid use disorder are markedly less likely to be offered a new patient appointment, and that's demonstrated by some of these secret shopper methods. And people in pain with substance use disorder are routinely undertreated because we as clinicians hesitate. And Angela felt this directly. Pain clinics wouldn't keep her once her UDSs came back positive, and years of care treated her more like a liability and not a patient with two intersecting conditions. So where does she go? Primary care, because we're really ideally situated to treat her, all of her issues. Next slide, please. So this is my practice. It's not a standalone addiction clinic or a specialty referral center. We're primary care that also treats addiction. We're a small but mighty team of 5, the nurse practitioner, myself, an RN, community health worker, a medical assistant, and office manager. And I emphasize this because we're small. This is something that's probably replicatable in other areas. Because it's primary care, Angela can attend one appointment and have her chronic conditions managed versus in silos as before. Everything happens under one roof. Those acute issues, the chronic disease management, prevention, screening, and substance use disorder care. We approach those in the primary care clinic that have substance use disorder with something called the OBAT model of care. That stands for office-based addiction treatment. This started out of Boston Medical Center and is really scaled through their Graken Center for Training and Technical Support. In this model, a nurse care manager is paired with a provider like myself, embedded in primary care to make addiction treatment as accessible as any other chronic disease care. That nurse will go into more detail about what she does, but her real role there is coordination and collaboration across the care team for that patient. That means with me as a nurse practitioner, her therapist, her recovery supports, pharmacies, getting prior authorizations, dealing with insurance, documentation, all of those things. It's also worth mentioning that we have to understand what the patient prioritizes. So patients tend to prioritize what's symptomatic, and chronic conditions that don't hurt day to day often don't make the list, which might be her opioid use disorder, but pain is usually way up there on the list. And when Angela first came to the clinic, her back pain is what she led with. It was constant, and it's what she really wanted addressed. I say that because sometimes pain is really a good entry point into substance use disorder care. It could be the one thing that gets that patient engaged in their care and not something that's a competing issue that we need to work around. For Angela, that looked like me and the nurse I work with willing to talk about her pain and opioid use together, and explain how one was affecting the other. And that was the first time that she felt that both parts of her health were actually being seen as one. Next. So I say this because clinics like this previously may not have been the norm, and the CDC recommendation changes from 2016 to 2022 kind of shape the care that actually work against patients like Angela. So it's worth mentioning and pointing out some of those changes. In 2016, this really covered chronic pain only for primary care outpatients, excluding things like sickle cell, active cancer treatment, palliative, and end-of-life care. In 2022, it expands to acute, subacute, chronic pain, and a broader range of clinicians as well, while keeping those same exclusions. In 2016, there were dosage thresholds, where there was an upper limit of 90 MMEs or morphine milliequivalents a day, with encouragement to stay below 50. What happened was insurers and healthcare systems widely converted these to hard caps, and that's far beyond what the CDC recommended. 2022 changes say those thresholds really aren't as hard as we were making them out to be, and it really gives clinicians like myself flexibility to build these individualized plans with our patients. So 2016 was kind of misapplied. It extended to patients it was never meant to cover. It led to sometimes rapid tapers and maybe abrupt discontinuation of opioids without patient collaboration, dosage caps, and then we had things like duration limits from insurance and pharmacies and outright patient dismissal. So perhaps Angela's history includes some of this misapplication. Pain clinics that discharge her rather than adjust care. And chances are many of you have already treated a patient who's gone through some of these similar things. So again, 2022 centers on flexible, patient-centered care and shared decision-making for any treatment change, including some of these opioid tapers that we'll talk about. Next slide, please. I put this slide in here because it's one of my favorite slides to talk about when we talk about medications for opioid use disorder. The CDC recommendation 12, and we just talked about that, tells us to arrange opioid use disorder treatment for these patients. And this is the evidence for the other half of Angela's diagnosis, the opioid use disorder. The number needed to treat. So this is simply how many patients you have to treat for one of them to get the benefit you care about. The lower number is better, but because it means that treatment or that medication is helping people more reliably. So for instance, to prevent one non-fatal heart attack, you need to treat about 104 people with a statin and about 100 people with an antihypertensive. These are really good, worthwhile medications that we prescribe every day without a second thought. Now, if we take a look at the medications that we use for opioid use disorder, we have naltrexone as one for abstinence, has a number needed to treat about 20. That's already several times more effective, and I know we can't compare apples to apples here, than some of our other medications that we readily accept in primary care. Buprenorphine, to keep one additional person in treatment, you need to treat just 2. And to suppress one person's illicit opioid use, again, just 2 patients. There are very few interventions in all of medicine that we have with a number that low. And this is really one of the most effective things that I've seen that we do in our primary care clinic. Next slide, please. So addiction is a chronic disease, and we want to treat it like one. We manage it over time with expected periods of flares and remissions. and the same clinical framework that we use for, say, asthma or diabetes. Flares and remissions with addiction are expected. These aren't shocking things. And that whole person care really can happen in one setting. Angela's first year with the gaps in attendance, inconsistent follow through, that really fits an addiction or a chronic disease model, rather. It was a flare in a chronic condition, not a failure of treatment. A positive drug screen means that we change the plan, we have more conversation, perhaps she needs more support. It doesn't mean we're going to discharge this patient from the practice. Discharging her for a symptom of her disease, really, we consider as not appropriate. In this disease, the discharge also has an associated mortality rate. That's really not giving the support that she needs at the time she probably needs it most. So OBAT, that office-based addiction treatment model, was the first place that really responded to the setback with a plan adjustment instead of an exit for Angela. Next. We briefly mentioned that Angela had a rough childhood, and we don't have to get into the details here, but what it looks like to keep someone in care through a flare. Now, we might want to back up and ask why the chronic pain and opioid use disorder so often show up in the same person to begin with. Researchers here surveyed more than 17,000 insured middle-class adults through Kaiser, and they found a graded dose-response relationship that 4 or more adverse childhood experiences compared with none carried a 4 to 12-fold increase in risk for alcoholism, drug use, depression, and suicide attempts. 1 in 6 people in that cohort scored 4 or more, 1 in 6. So we see these patients every day. We might not know it or recognize it, and that's not something that they divulge readily, right? The literature also links adverse childhood experiences to higher odds of chronic pain in adulthood. So we know Angela had this rough childhood, and what may look like poor choices in adulthood many times may be a survival strategy that started decades earlier in circumstances that perhaps she didn't choose. And a lot of the patients that we encounter kind of fit this same pattern. They're not making bad choices so much as that they're trying to survive what perhaps had happened to them. Okay, you can move on. So a little bit more about the OBAT model of care within our clinic here. Knowing that Angela is suffering from chronic diseases, her chronic pain, and her substance use disorder, in the context of a perhaps traumatic childhood, previous poor experience with the healthcare system, she's working to gain employment, she's working to get stable housing, she wants to care for her children, and knowing that her story is common and that each individual has their own story, let's take a look at what the nurse does to try and make this a seamless interaction for her. First, the screening and intake. Often the first person in her healthcare who's asked these questions without judgment is the nurse that I work with, Michelle. Angela has already been discharged from 2 pain clinics, and she's cycled through emergency departments before she got here. When she called the clinic, she was directed to Michelle, who I'll mention is a certified addiction nurse as well, and who performs a telephonic intake that includes a brief substance use disorder history, pertinent medical history. She makes her appointment and then connects her with our community health worker for transportation assistance to get to that first appointment. Michelle and I meet with the patient, and my side as a nurse practitioner looks much like a normal patient primary care interaction with an included substance use disorder assessment and treatment plan added on. Michelle and Cecilia, my community health worker that I work with, spent a bit more time with Angela at these first visits to find out what her social determinants of health needs are, what resources we can help with. And once buprenorphine was started for Angela, we have close follow-up that was arranged telephonically with Michelle, the nurse care manager, over the first week and with me over the next month. Because the nurse is leading this help for Angela, especially during her first month or two, it allows me as a provider to see more patients like her. It allows Angela to receive that one-on-one care that's needed, especially early in recovery, and more people are able to get that care. And Graken through Boston Medical Center really frames this as an arc. You have the initiation, you have stabilization, and you have ongoing maintenance and support. And most of the patient's time in treatment really is spent in that last phase, the ongoing maintenance and support. And that's really nursing territory there. Angela is 2 years into it now, and she's housed, she's employed, and she's working on parenting as well. Next. So as a nurse myself, I have to toot our horn here and why nurses are perfect at this role. You know, chronic disease management and patient education are not new skills to nurses, and they're really core nursing skills. And addiction simply joins the list of conditions that are already managed as chronic conditions. And Graykin and BMC said this directly. The registered nurse's scope of license and expertise in chronic disease management and patient education make nurse care managers ideally suited to deliver ongoing care for substance use disorders. Really, this is the person who has seen the patient 20 times, who knows her baseline, who knows when her affect is off, or her pain sounds differently than perhaps it did last month, or when she's struggling. And I, as a provider, I might just see a slice of that. The nurse really sees that trend line over time. And it's the same as, when we're in the hospital, who spends all day with the patient and is likely to notice these slight changes. That's nurses. That's why this model is really scalable on nurses rather than me as a nurse practitioner or perhaps a physician. There's not enough of us, and there's not enough time to go around to commit to Angela. And for Angela, she sees me episodically, and she sees the nurse Michelle every visit. And the nurse is really who builds a lot of that relationship with and who she tells things to. Michelle knows when Angela has big milestones and celebrates with her. For instance, Michelle was the first person Angela contacted when she reached 2 years of sobriety. I think those are the kind of things to mention are important. Next, please. So it's worth mentioning the language that we used and how that develops trust within our patients. And that is really tough to do with someone like Angela, who's been dismissed by the healthcare system for several years. Her trust did not come from that first visit. It came from many good visits over time. The same people showing up for her and including, making sure she's included even through a spotty first year. We also want to make sure we're managing expectations with Angela with her opioid use disorder and her chronic pain. It took years for her to get there, and it's going to take time to work it out, but ensuring that we're willing to work it with her, and that improvement does take that time. So a note a little bit about language. There's this 2018 study in the Journal of General Internal Medicine that had physicians in training read identical clinical vignettes, varying only the terminology. And those who read substance abuser were more likely to view patients as personally culpable and deserving of punitive action, and less likely to think the patient needed treatment compared to those who read person with substance use disorder. That language is so important. And the language is common in practice. It's really not rare. There was another 2023 audit of over 500,000 clinical notes that found stigmatizing language in 18.4% of them. So in our clinic, new staff are really trained on appropriate use of language, not only in how we speak to the patient, but also in our documentation. That first phone call that someone makes who's struggling with substance use disorder, that might be the hardest phone call they've ever made in their life. So for the person on the other end of the phone to say something that, "Oh, we're so glad you're called, I'm happy to help you," makes a world of a difference. And that should really be the message that comes across when this appointment is made. I mentioned documentation also because that's important. There's stigmatizing versus non-stigmatizing. Something stigmatizing might read, "Patient is non-compliant and drug seeking." I'm a former emergency room nurse. I've seen that, right? A non-stigmatizing way to document that same thing might say, "Patient declined the recommended treatment plan," or "Patient reports uncontrolled pain, seeking further evaluation." Another example might be, "Patient was unmotivated, resistant, and uncooperative during the session." Instead, a non-stigmatizing way, "Patient expressed ambivalence during the session about changing habits and reported barriers to going to group therapy." So why is this important? Because the next person who reads that note is going to make assumptions based on what we're documenting. So these things have weight behind them. Next. All right, so getting back to Angela's chronic pain here. At this point, we've established how we are establishing rapport with Angela. We're building that trust, and she's working really hard. She's doing the work to become healthy, and she feels like she can open up to the staff at the clinic. And when she's talking, you need somewhere to take that conversation. And when it comes to her chronic pain, we start with what her life actually looks like and not just some kind of pain score. So we look at function, ask what her days look like, and build a plan backwards from that answer. So our nurse care manager uses a goal setting approach, how they spend their days, what they wish they could do, but now can. Angela's goal wasn't a 4 out of 10 average pain score. It was that she wanted to work a full shift and still have a bit of energy after dinner to do something she enjoyed, like walking her dog. And that became her SMART goal. It was specific, measurable, achievable, it was relevant, and it was time bound. And it was something in 6 weeks from now that we can assess together. And behavioral interventions are some of those safest, the most effective treatments for chronic pain. And there's formal CBT protocols. They're obviously a great intervention and one that we heavily recommend. But goal setting, this physical activity, sleep, mood, these don't require a clinical psychologist to deliver these. RNs can deliver some of this education, right? This isn't something that was done over one appointment. These are suggestions, small suggestions that are made over several appointments. And none of these single interventions for chronic pain have a very large effect size. The strategy here is to stack several modest ones and find what works individually for that patient. Next. So her back pain is treated without a full agonist. That's the toolkit for pain when the answer isn't opioids, but Angela's regimen really isn't opioid free. She's already on one. She's on buprenorphine for her opioid use disorder, which is a new opioid agonist. What hasn't been done is layer a full agonist on top of that for her chronic pain. Buprenorphine here is prescribed for the opioid use disorder. It's not as a pain medication, but it does provide some of that baseline analgesia incidental to why she's on it. And it's not sufficient on its own for her chronic back pain. So based on that CDC 2022 ASAM guidelines, we do these graded exercises. We recommend physical therapy plus a daily walking program. She's got some CBT-based pain management, keep a sleep routine, topical NSAIDs, short oral courses for flares in her pain. And then most importantly, we're measuring via something called PEG. And there's 3 questions that are scored 0 to 10, pain intensity, enjoyment of life, and general activity. And this is validated for primary care under a minute, and it's valuable for trends to really measure how she's doing. And the question we want to keep coming back to as well is, how do your pain and recovery, how are they affecting each other today, if at all? Next. So I want to pause here and talk a little bit more about buprenorphine and how some of the medications for opioid use disorder act on this mu opioid receptor. Mu receptors are a key part of our nervous system. They control pain relief, euphoria, and breathing as well. So there's 2 separate properties that decide how these drugs behave at that mu opioid receptor. One of them is affinity, how tightly it grabs onto the receptor and how long it holds on to. And then there's the intrinsic activity, how strongly it switches on that receptor once it's bound. A full agonist here on the left, like methadone, also heroin, oxycodone, fentanyl, that switches that receptor fully on without an effect climbing. There's no ceiling. And that's why a full agonist can kill. Respiratory drive falls as dose rises with nothing to stop it. Buprenorphine here in the middle is a partial agonist. It binds very tightly. It has a very high affinity, but it only switches that receptor on halfway. And because this activation plateaus, there's a ceiling on respiratory depression, making buprenorphine safer in overdose than a full agonist. And then lastly, on the right, naltrexone is a pure antagonist, has high affinity, 0 activation. It blocks that receptor without turning it on. And because that block is complete, the patient, if they're going to start this for opioid use disorder, might be fully off opioids for 7 to 10 days before the first dose, or it can do something and put the patient in something called precipitated withdrawal. And one note worth separating, naloxone is also an antagonist, but that's that short acting used to reverse overdose in the moment. That's for rescue, not treatment, not to be confused with naltrexone, the long acting blocker that sometimes we use for maintenance for opioid use disorder. Next. So buprenorphine and pain, let's talk a little bit about that. Here's what applies to Angela's regimen. Sometimes we'll look at split dosing. For opioid use disorder, once daily buprenorphine can work for the anti-craving effects because it can last a long time. The analgesic effect is considerably shorter. One strategy for more pain relief from the same medicine is to divide the total daily dose into additional doses. It may offer more meaningful pain control than once daily dosing. And for Angela, the twice daily dosing of 8 milligrams has provided her with a practical move forward to control pain. She doesn't have to take the buprenorphine with her to work for additional doses, and she can get through her shift okay. She receives 16 milligrams a day and 2 divided doses. And that decision really belongs with me as the nurse practitioner. But I will mention that Michelle, the RN, can recognize a patient who may benefit from split dosing, and she's made those recommendations before. A second note is that formulations for buprenorphine are not interchangeable. We also have buccal films and transdermal patches. Those are dosed in micrograms, not milligrams, and those are FDA approved for pain. The sublingual tablets and long-acting injectables, those are dosed in milligrams, and those are approved for opioid use disorder. They're different products. They have different indications, different doses. So a patient's buprenorphine is not automatically the same molecule and form as the last patient's. So Angela is on sublingual tablets, dosed for opioid use disorder, or films rather. There's another study I want to mention, a meta-analysis in pain medicine that found that buprenorphine has a beneficial effect on pain intensity overall. A small effect size in patients with comorbid chronic pain and opioid use disorder, and a moderate to large effect size in chronic pains with opioid use disorder. Next. And then so far we talked about Angela controlling her opioid use disorder, getting her pain controlled, and another piece about what's in place if something goes wrong, and that's starting with naloxone. So every patient who comes into the clinic and has a substance use disorder, we're giving them naloxone education and access. It's offered to anyone who uses substances, not just patients with opioid use disorder. Why do we do that? Because there's contaminants in our drug supply. We have to assume that there's fentanyl present. Angela was offered this on day 1, and the same proceeding throughout her course of treatment. We also do a lot of overdose prevention. Things like we're never using alone, go slow after any gap in use because of dependence and tolerance decreases. And we're assuming fentanyl is present. We also talk about safe storage of buprenorphine. We mentioned that she's got kids in her house. Is it locked, labeled, it's out of reach? And we teach that at the refill visits as well. Naloxone is taught the same way glucose tabs are taught for diabetes, for instance, routinely teaching this for a chronic condition, right? This is not a signal of distrust. We're just teaching because this is what we do for chronic conditions. And then it's worth mentioning for Narcan, the teaching family members and friends to use it. Angela's parents, who are back in her life and helping with the kids, were present for one of these appointments so they could also learn how to use this, because if something happens, they're more likely to be the ones who are there to supply and help. Okay, next one, please. So because opioid use disorder is the thing I teach about most, I have a couple of things to break this up, myths or facts. So we'll have a poll here. 4 claims that you hear about medications for opioid use disorder, sometimes from families, colleagues, and sometimes from the patients. And if you could just respond, we'll get this going. Okay, so myth or fact, treating opioid use disorder with buprenorphine or methadone is just substituting one drug or addiction for another. And I'll give you a minute or two to throw that in there. All right, that should be enough time. All right, so can you guys see that results there? Myth, 95% of you select myth, 5% selected fact. Could you go to this section of the slide, please? And the reveal. All right, great. So a lot of times we'll even hear this from patients, right? And family members of those receiving buprenorphine. There is a difference between physiological dependence, but that does not equal addiction. Addiction is a behavioral syndrome, that craving, loss of control, compulsive use, and that use to start harm. A patient stabilized on these medicines has none of those four. They're working, parenting, rebuilding, those types of things. And dependence is an addiction. We don't say the same thing for a patient on an SSRI or a beta blocker that we can't suddenly stop or suddenly can't be stopped abruptly. This is a predictable pharmacological property of the medication. Okay, nice work. Next. Okay, so next one, medication for opioid use disorder is appropriate for short-term treatment, but not for long-term. All right, and the review, please. 88% myth, 12% say fact. All right, very good. And can we have our rationale? All right, it's a myth. The protection comes from staying out of it. Stopping is sometimes can be the dangerous part. So the protection from overdose and retention of care both come from staying on the medication. We have data that says that most people who stop buprenorphine return to opioid use. And the period right after stopping is the most dangerous time in that window because tolerance has fallen while relapse risk remains high. So again, we treat this like any other condition. The patient stays on the treatment as long as it's helping, which for many people means years, but for some people that could mean indefinitely. Not for everybody, but for some. So describing medications for opioid use disorder as a brief course sets the patient up to fail. And it quietly tells them that stopping is the goal. Describing it as an ongoing chronic condition that needs assessment frequently sets them up for success here. Okay. Can we skip the next two so I can wrap up my slides on time? Perfect. All right. So in our patient here, she has a routine visit, and after almost an afterthought, Angela mentions that the pain is different now. She's got a new location. It's in her mid back. It's not in her lower back. It wakes her up at night, and nothing that used to work was touching it. And she says something that was a bit heartbreaking. I didn't want you to think that I was after more buprenorphine. She had the rapport with our nurse. She was able to tell her this. We have to recognize that chronic pain fluctuates. There are better and worse days, and a flare is an expected part of the disease. To sort this out, is what you're feeling, to ask her, is what you're feeling within the range of your typical worst week, or is it outside of that? Hers was outside of that range. She has a new location. She has pain at night. It's a failure of an established regimen. So this was a red flag for me. It led to imaging and found metastatic breast cancer. So it's worth mentioning too that patients with opioid use disorder are the patients that are most afraid to report escalating pain because they have learned what happens when they typically do. There's one study that said nearly 600 primary care patients with chronic pain worry about reporting pain to physician was significantly higher among those with opioid use disorder than among those with other substance use disorder. So also for nursing literature, pain in patients with substance use disorders is underestimated and undertreated. And unrelieved pain then produces behaviors that get read as drug seeking, which stigmatize the patient even further. Next slide. So who's willing to treat her pain now? Her situation has changed dramatically, and she has SUD history that makes some prescribers nervous, and oncology teams may hesitate because she has opioid use disorder, and addiction programs are clearly not built for cancer pain and won't touch it. Next. So I picked up the phone and I called Deborah's clinic. I made a phone call with an office referral, an official office referral. I gave her not only just a one-line referral, but her chart, her story, her buprenorphine dose, her goals, her work and family situation, and my direct number. and reassurance to Angela that the referral wasn't discharged from primary care. We remain her medical home, but recovery support and monitoring throughout her treatment through the discharge that follows. Next. So I'm going to lend this over now to Deb Russell, who will talk about what that looks like from her side.
Hi, everyone. Thanks for having me. Thanks, Liz. So just to continue on with Angela's story. So I get a call from Liz. We talk about Angela over the phone. She places the referral. And so we decide that we're going to coordinate our care with Liz's clinic, and we decided that we would have frequent communication about Angela and how we were going to manage her care. So she places the referral. A little bit about our clinic. It's a very unique clinic. We are a clinic that specializes in addiction and cancer-related pain. A little bit about our history. In 2020, we were noticing when patients were hospitalized for cancer and for cancer-related symptoms that there were a lot of patients that had substance use disorder that weren't able to get cancer treatment in light of their addiction. Basically, there was a lack of knowledge regarding how do you treat pain, acute cancer-related pain with addiction. So we looked at our addiction medicine colleagues and thought maybe that would be the good group that would be able to manage this group of patients and their pain, but they have great experience with addiction, but not a lot of experience in managing pain. And then we looked at oncology, thinking, well, oncology would be able to manage their pain in light of their addiction, but that didn't work out so well either. So we went back to our palliative colleagues, and we are known for our symptom and pain management, but we're not addiction specialists, and there was even some hesitancy and lack of knowledge within our own group. So we consulted with the legal department and wanted to make sure we were practicing within our scope, and they gave us the green light to develop this clinic. So the clinic was developed. We're not addiction certified. We use the principles of harm reduction, which I'll discuss later, with the goal of managing someone's pain safely who has a substance use disorder. Next slide. So the goal of our clinic is to safely manage cancer-related symptoms like Angela's, and that she's a very common patients that we see that are impacting her quality of life. Our clinic uses the principles of palliative medicine, addiction management, and harm reduction in patients that have active or previous substance use or misuse disorders who are undergoing cancer treatment. These goals we hold tightly to, and I'll get into the team shortly as far as who's on our team. Next slide. Next slide, please. Thank you. The referral criteria for our clinic. Angela fits nicely into this criteria. You have to have active cancer. It's managed mostly here at the cancer hospital. A prior history of active opioid use disorder, use of illicit or recreational substances. Some of the examples I see are cocaine, methamphetamine. We do see alcohol use disorder or high-risk alcohol use. We don't strictly see folks that have solely cannabis or tobacco use disorder. The one thing I want to stress is these principles and recommendations that we're talking about can be implemented in any clinic or healthcare setting. Next slide, please. So I just wanted to give you just a little idea of the substance use disorders we see in the clinic and the percentages. This was taken from a paper that we published in 2024 about our clinic. You can see we have a high propensity of patients that have cocaine use, OUD, or history, methamphetamine, stimulant use disorder. We are seeing more patients now that have a cannabis use disorder, and of course, alcohol use disorder. Next slide. So I want to spend a little bit of time here as we talk about harm reduction and how you can apply the principles of harm reduction into any healthcare setting. So this clinic was founded, and we stand on the principles that you'll see here that Mary Hawk and her colleagues published a paper on. This is adapted from Table 1 in their article. And you can see some of the things like humanism, treating patients with dignity, respect, and compassion, recognizing their humanity regardless of their health behaviors. And the big thing, the area I want to just mention is avoiding judgment and stigma. We pride ourselves on that in this clinic. Pragmatism, abstinence is not to be assumed to be the goal of Angela as we're meeting her. We want to make sure there's a safe use of substances, using practical evidence-based strategies that work in real-world contexts. Individualism is very important. No one size fits all. Adjusting your opioid prescribing based on needs and risks. Autonomy is shared decision-making, offering the patient choices when possible. Incrementalism is you're going to celebrate accomplishments. And, in our clinic, we celebrate accomplishments by coming to their appointments consistently. That is a win. As a lot of our patients, as you know from the social determinants of health, transportation is an issue, housing is an issue. And so when they can get to their appointments with us, that's a win. Moving straight to abstinence is not necessarily a requirement. Making small, manageable changes to reduce harm over time. We also have accountability without termination. We believe that patients are responsible for their choices and health behaviors while avoiding punitive measures. A patient who relapses on medication is supported back into treatment rather than dismissed. These principles, again, can be applied to any healthcare setting. Next slide. So I want to lay out what Angela's first clinic visit would look like. So she comes in, and we have a great nurse, and she does the intake assessment. She provides an overview of the clinic. We have a folder that describes our clinic. She's seen by the physician, and she is also seen by a pharmacist. We describe our clinic to her as an added layer of support for her cancer journey as she's getting treatment. We do use a pain agreement. Patients will read that and sign it. We do a thorough assessment. It's usually a 60-minute visit, and we assess pain and symptoms. Is it cancer-related? Is it chronic pain? And Angela's coming to us with a history of chronic pain. So we have to be very clear in our assessment. Is this cancer-related or is this chronic-related? And we will tailor our care plan around that. We use or recommend a lot of adjuvants, both pharmacological and non-pharmacological. Things like physical therapy and massage therapy and acupuncture. I will tell you it's difficult sometimes with transportation to get folks to those appointments, but we really try. We do also an assessment of the patient and caregiver needs. We coordinate additional support. On our team, we have a social worker who is in the clinic with us. We also have a harm reduction counselor that we can schedule visits with. We also have psychiatry and addiction medicine. They are not on site in our clinic, but we do have access to them. We can place formal consults, and we can also do curbside consults. We work closely with both psychiatry and addiction medicine. We do a thorough medication review. We've noted that she's on buprenorphine, 8 milligram twice per day, and has been on that for a period of time. We do naloxone education, and we provide naloxone out of our clinic. The other thing about our clinic is we discuss pill counts and having patients bring their pills in so that we can make sure that they're taking them the way they're prescribed. We don't provide early refills on medication. Now, keep in mind, this is done on the first visit. So what we're doing is we're setting expectations for this clinic. We discuss safely securing their medication. We have drug disposal bags in our clinic, and we also have fentanyl test strips. If someone is at high risk and they're using a lot of non-prescribed substances, we can give them fentanyl test strips and discuss that on their first visit. We administer something called an ESAS, or an Edmonton Symptom Assessment Screen. That's a tool used in palliative care for symptom assessment. We do something called a PHQ-9, which is a patient health questionnaire. It has questions on it that the patient completes. So they're giving us self-reporting of their symptoms. And then we collect a urine drug test. And I'll talk just a little bit about urine drug tests a little bit later in the presentation. So we have a discussion with Liz regarding who will prescribe the buprenorphine. So we decided mutually that we would pick up prescribing her buprenorphine while she's getting cancer treatment, with the goal of transitioning her back to Liz's clinic when her cancer disease has stabilized. Next slide, please. Now Angela comes in for a follow-up visit, and usually that follow-up visit can be anywhere from 3 to 4 to 5 weeks once she started treatment. So then she'll see me, and she's either scheduled for a 40 or 60-minute visit. At that time, every visit, we administer those. We administer the PHQ-9 and the ESAS that she has done in the beginning. I also incorporate a whole person assessment on my first visit. This includes a substance use history, and I also do a thorough pain evaluation. I look at increased pain. She's now having both neuropathic and nociceptive pain. If you know how to do a good pain assessment, you can really tailor your decision-making regarding opioids surrounding that. So I determined she has neuropathic pain, which is a lesion or disease affecting the somatosensory nervous system, peripheral nerve, spinal cord, or brain. And she also has something called nociceptive pain. And this is the most common type of physical pain caused by somatic pain, visceral, and specialized nerve receptors called nociceptors. It acts as the body's natural alarm system to signal actual or potential tissue damage. I review with Angela pharmacological agents, like if she can take a neuropathic agent, if she's able to take any type of an NSAID, and any non-pharm interventions like acupuncture and PT, if that's something that she wants to consider. So now we start to talk about if she needs a full agonist in addition to her buprenorphine. Now, we determined that she would benefit from a full agonist opioid. Now, some of you may wonder how you can prescribe both buprenorphine and a full agonist. And I will demonstrate that as I go further along, that you can, with the expectation that we would continue the opioids with the goal of tapering at some point with a return to her previous provider, Liz. Next slide, please. So this slide really does a nice job of how can you add in a full agonist with buprenorphine. And I get a lot of questions about this, just because I think there needs to be more knowledge provided to clinicians that you can. So I get questions about, so you might wonder, does naloxone block the opioids? So naloxone and buprenorphine is included primarily as an abuse deterrent. Now, we have this conversation with patients all the time when they're hesitant to go on a full agonist in addition to their buprenorphine because they don't think the full agonist is going to work. So when the medication, the buprenorphine, is taken correctly under the tongue or inside the cheek, naloxone has very little effect, but because it is poorly absorbed by those routes. However, if someone attempts to dissolve and inject the medication, the naloxone becomes active and can precipitate opioid withdrawal in a person who is opioid dependent. This helps discourage misuse by injection. So in summary, naloxone is not there to treat cravings. It prevent overdose during normal use or make buprenorphine work better. Its primary purpose is to deter injection misuse. I hope that's helpful. So you can see from this slide that you have some you have some place on the receptor that is still available for you to use a full agonist. So just keep that in mind. Next slide, please. So I'm going to come back to the beginning because this is something that all providers should know. If you're going to start an opioid therapy, you really need to be mindful about when you start it, the dose that you're going to start it at, and you have to have an exit strategy. And you need to start with the end in mind. And you have to have the conversation with the patient in the beginning when you start the opioid about what you're going to use it for and how long you're going to use it for. And you have lots of conversations in between. There is a tool called the ORT, and it's the opioid risk tool. And I will show you that tool in the next slide. It's a great tool. It's a fast self-report form, and it's looking at family history, personal history of substance abuse, and age. You can give the tool in minutes, and it can tell you if someone is at high risk for an opioid use disorder or risky opioid use. We use a patient-provider controlled substance agreement. We run a prescription drug monitoring in Ohio. It's called ORS. Every state, it's a little bit of a different name, but I can run that report and I can see what prescriptions were filled last, their fill history, how often they're refilling it. I will individualize opioid endorsing based on their use, and I review the benefits and risks of opioid therapy. Next slide, please. So this is the tool. This is the ORT tool. You can complete it in less than 1 minute. It doesn't diagnose OUD, but it will tell you if someone is at higher risk and also then supports safer opioid prescribing. You can see family history, personal history, age 16 to 45, history of pre-adolescent sexual abuse, and psychological disease. Next slide, please. So now we have Angela on hydromorphone. And what we decided was that we would change her buprenorphine dosing to 4 times per day. Breaking it up 4 times per day would provide some analgesia for 6 to 8 hours, and we would add in 4 milligrams of hydromorphone. So now she's on opioid therapy. So now for risk mitigation, we're going to do things like pill counts. We're going to continue to talk about naloxone, especially since she has children at home. The guidelines for urine drug screen, they're using terms like toxicology testing now versus urine drug testing, because we know that we can do drug testing on urine and oral fluid. There's a new test that we've started to use called the PEth. It can detect alcohol in the blood for the last 2 to 4 weeks, where a urine alcohol test will detect the last 1 to 5 days. And then saliva and breathalyzer in the last hour. So that's a new test that we're now starting to use. We're also looking at careful prescribing of other CNS depressants. We're continuing to check our drug monitoring programs. And we're also every visit screening for conditions that can complicate pain management, like anxiety, insomnia, or other co-occurring substance use disorders. So the CDC does recommend, and with the guidelines from 2022, they do recommend considering toxicology testing before starting opioid therapy and periodically during treatment, but at least annually if you have someone on opioids. Using testing to identify that the prescribed opioid is present, that they are taking their controlled substances as prescribed, and that they're taking them safely. Next visit, or next slide, thank you. So Angela is now coming to our visits, and she is attending her appointments. She's engaged in her care plan. Her urine drug testings are appropriate. She's consistent with her refills, and now her cancer is stabilized, and she's ready to return to Liz's OBOT clinic. So now we're going to enter the phase of tapering, and how do we taper it? Immediate release opioids. So I'm going to talk just a little bit about tapering because I think it's really important that we're all aware of it. Next slide. So Why are we seeing more opioid tapering? So the Arnold study that I've cited here found cancer treatments have improved over the last 20 years, contributing to better 1 in 5 year survival for nearly all cancer types. More patients are achieving no evidence of disease and transitioning into long-term survivorship, creating a growing population with ongoing healthcare needs beyond active treatment. Survivorship does not, however, always mean symptom-free. Many patients experience long-term treatment sequelae such as neuropathy, chronic pain, fatigue, lymphedema, bowel dysfunction, or cognitive changes that require ongoing management. Cancer is becoming a chronic disease for some patients. Advances in systemic therapy with metastatic or recurrent disease live for years with stable or largely stable disease. This increasing number of long-term survivors raises questions about chronic opioid therapy. Some patients remain on opioids for cancer-related pain or treatment-related pain long after the completion of active cancer treatment. Next slide. So these are the potential benefits of opioid tapering. Lowering the risk of opioid adverse effects, including overdose, functional improvements. For example, feeling more alert and clear-headed, having more energy during the day, less constipation and other side effects, improved sleep and mood. There are a lot of potential benefits. Next slide, please. Potential harms. So we have the benefits and now we have the harms. Opioid therapy, I think we all know, should not be discontinued abruptly, except in life-threatening issues. This is a collaborative effort between the provider and the patient. You can have a harm of withdrawal symptoms like increased anxiety, insomnia, pain exacerbation, worsening mental health. Forced tapering can lead to feelings of abandonment, loss of trust in the healthcare system, depression, and increased anxiety. And then there's a risk of seeking alternative opioid sources. Patients may seek opioids from non-medical sources, including risk of harm. Next slide, please. This is just a really great slide for opioid best practices. Do you taper or not? The dose and length of therapy is important. If you're going to taper, education on proper disposal techniques, drug take-back programs, and disposal bags and systems. Next slide, please. This is a slide, and I know we're running out of time. What opioid should I taper first? And I always get this question. It's generally reasonable to taper the opioid contributing to the greatest risk and the least benefit. This often means reducing the short-acting opioid first. Next slide, please. I wanted everyone to have this slide because this is the speed of a taper. And it really does lay out, if you've got somebody on shorter term opioids, how do you taper them? What do you do? So I want to just back up a minute about the definition of pain and acute pain. Acute pain is less than 1 month. Subacute pain is 1 to 3 months. And chronic pain is greater than 3 months, 90 days. Tapers of less than 10% per month are better tolerated in patients on chronic opioids. All along with patient collaboration. Next slide, please. This is just another slide that is really helpful, how much to taper. We have patients that perhaps it's reasonable to taper 5% if they've been or less a month or longer who've been on chronic opioids. Individualize the taper, focus on function, not just dose reduction, optimize non-opioid therapies, monitor closely and reassess, and shared decision-making. Next slide, please. Additional support during the tapers. We've talked about this, optimize non-pharmacological strategies, review and enhance non-opioid analgesics, frequent follow-up, and optimizing comorbid mental health conditions, because these can change over the course of the taper. In Angela's case, I'm aware she has support through Liz's clinic, and I make a referral to our team counselor to follow her while she's under our care. Next slide, please. The long-term effects of chronic opioid therapy, and I'm not sure many providers or clinicians know this. Patients that are on opioids greater than 90 days, there is an associated risk for opioid use disorder. And there are harmful effects of chronic opioid therapy. And you can see some of the additional documented harm. Increased risk of MI, fractures and falls. There are endocrine issues, sleep disordered breathing, new onset of depression, especially with patients that have been on opioids for greater than 30 days. There can be cognitive impairments. They have a higher incidence of hyperalgesia, and hyperalgesia is more pain that would normally be expected from a painful stimulus. Patients may report worsening pain despite increasing opioid doses, pain that becomes more diffuse or widespread, increased sensitivity to touch or painful stimuli, pain that seems disproportionate to the underlying condition. Next slide, please. These are some resources for tapering. So you can look at the 2022 CDC guidelines and the HHS guide for clinicians on the appropriate reduction or discontinuation of long-term opioid analgesics. An important note that I want to bring up is much of the data that's used to create these guidelines excludes cancer and palliative care patients. We need to be included in that as patients are living longer and are on chronic opioids for a longer period of time. Next slide, please. So some concluding thoughts. So utilizing harm reduction strategies, risk assessment tools, and engaging the patient in patient-centered care, collaborating with primary care and other providers on the patient's medical team. These work well in any practice environment. So I want to challenge you all, to not be fearful of taking care of patients that have a substance use disorder, an opioid use disorder. Care for patients with OUD, cancer, and addiction is essential for health equity. Our approach is one model that made sense for us. Other models work as well. The principles are what is most important. Thank you all for listening today. I appreciate your attendance and your interest in this group. It's something that means that a lot to me, and I'm sure to Liz as far as our practice.
Liz and Deb, thank you so much. What a great presentation. We have some time for question and answer. So Liz and Deb, I'll join you or ask you to join me on camera here as questions come in, but I'll start off with one. What would you say to a colleague who's uncomfortable continuing a full dose of buprenorphine while patients getting opioids for cancer pain?
It's tough. It's tough. That's the best I can. It takes a lot of education. I have to say that I work with a great pharmacy team here at LSU, especially in the palliative and harm reduction clinic, and we do a lot of education. I think we've seen a change in our practice in regards to being hesitant to prescribe both buprenorphine and a full opioid agonist or full opioids. I think that they're getting more comfortable, but we still have a long way to go in educating people that it's okay, that there are some nuances to it, but we can help walk you through it, and we can help educate you on safe ways to do it. There's just a little bit about the physiology, and we talk a little bit about pain receptors. There is room on the receptor. Buprenorphine does not take up the whole receptor, and so you do have room to add a full agonist safely. And we can do that, and we can do it safely, and we do it every day here in this clinic. But you need to provide the education to the clinicians that aren't in our clinic to be able to be comfortable with doing it. Instead of just, you have someone with cancer-related pain and they come into the emergency room and they see that they're on a buprenorphine product and they say, we can't help you, we can't give you anything. That's really doing a disservice to the patient and not really treating their pain, because their cancer-related pain is legitimate, or any type of acute pain that they may have. I hope that wasn't the long-winded answer to your question, Mike.
No, that's a great answer. I know it's always a challenge. I'm going to throw another one at you, and I'd like both of you to kind of chime in on both. how you would think about this situation now, but also how you thought about this maybe 10 years ago before you gained all of this incredible experience. So the first time or even now when you encounter a patient that has history of OUD in their chart, have you ever hesitated to give them an opioid, and why?
Yeah. I mean, I can tell you as somebody who, this is what I do and I live and I breathe day in and day out. But if you would have told me 12 years ago this is what I'd be doing, I probably would have laughed at you. And I think when we first started the SUD program at the clinic and started with prescribing more of these buprenorphine products, that was when X waivers were still a big thing, and nurse practitioners needed 24 extra hours in order to do this. So even the education was a bit stigmatized. What other medication do we have that you need that much extra training in order to prescribe? I could prescribe morphine, no problem, but I needed 24 hours extra education to prescribe this buprenorphine. So yes, I would say absolutely. I think I've grown in that way as I've treated more and more of these patients over the years and really seen what kind of stigmatizing care that can be given and how detrimental that can be to that individual. So I would say I've grown tremendously over the past several years in treating these patients. I think that was a roundabout way of answering your question anyway.
Deb, what about you?
Yeah, I would say I've been in palliative medicine a long time, so I've been used to prescribing opioids. But when we started to use buprenorphine inpatient, it took a lot for me to come around to saying we can still use a full agonist in addition. So I would agree with that. It took me a little bit to come around to that, but also the education. You need the education, and you need to understand, the pharmacology, and you need to be comfortable with it. Yeah.
Yeah, great point. So there's a plaque right above where my camera's at that our team got me years ago, and it says buprenorphine. I can explain it to you, but I can't understand it for you. And I think that comes from just like kind of being scared about a drug that is a little bit more complicated. But once you get used to it, it's a really effective medication to use for pain, for opioid use disorder, for all sorts of things.
Yes.
And a piece of data I like to tell people, when we see OUD on somebody's chart, we almost always think, oh, they're drug seeking. But there was a nice qualitative study, and it looked at factors that are associated with being labeled a drug seeker. And the one that gets me every time is that anybody that names a medication by brand name is going to be like, they're more likely to be labeled a drug seeker. And I would argue that that's basically every healthcare provider when they ever go and seek care is going to say, oh, I think Dilaudid might help. Well, now you have the potential to be labeled that, right? So taking in the context of how we're taking care of patients, if we ourselves could get that label simply because we know more, maybe it should give us a little bit of pause.
Yeah, I agree.
So let's think another question here about clinical decision making. So when you have a patient who's on a stable dose of buprenorphine and they come to you and their pain is now 9 out of 10, what's your first instinct, and what do you think that care plan looks like for that patient? What questions are you asking? What decisions are you making?
Liz, do you want to answer this? Do you want me to answer this?
Yeah. So first, if we've got an increase in pain, I want to know about that pain. I want to do a pain assessment. I want a good history and physical exam on that patient. What is causing this pain? What's the etiology? Why do we think this is happening? In the back of my mind, I know buprenorphine works as good as any other opioid, I suppose, for pain and pain management. But I want to know what else we can do before we make that big, large step to increase that medication. So first, getting at the root cause of the problem and seeing if there's something else we can do as an adjunct. Is this musculoskeletal? That's something that we can look at. Our physical therapy and those types of things. And I want to hear the patient too, right? So recognizing that I hear what you're saying is a big leap. 9 out of 10, must be awful. And let's talk about what that looks like moving forward.
I think the challenge that we see, going off what Liz just said, is when someone has cancer and active cancer, and they come to us with chronic pain, how do we discern what's chronic and what's now cancer-related pain? And that takes a real fine assessment and a lot of conversation with the patient, because most of the time they can tell you, this was my chronic pain and this is what I'm feeling now. So everything that Liz said as far as her assessment and talking with the patient, that's going to determine for me if I'm going to change the care plan as far as their medication regimen. You know, it might be that I have a head and neck patient that's in the throes of radiation and chemotherapy, and I need to adjust the buprenorphine to 3 or 4 times a day from a twice a day dosing. And I may need to add in a small dose of an immediate release medication, knowing that I'm having the conversation with the patient frequently as far as the pain and what their needs are. But I do think when they come with chronic pain, you know, you've really got to do a careful assessment of what's new and what's old.
That's great. So I'm going to have one final question for the two of you. So if you have your audience take one message away from today, what is the one thing you want them to walk away from with?
I would say that pain and addiction, that reciprocal model, that they feed each other, and that these are both chronic diseases that can be treated. And, you know, that stigma is often what keeps that connection hidden from the people like us that are really trying to treat it.
And along that lines is patients are more than just their addiction. You know, they're human beings. They have families and they have lives, and unfortunately, they have an addiction issue, and that just goes along with who they are, approaching them like they're individuals, and that they have a purpose.
Great. Thank you both so much. If we could have the slides put back up, we're going to round out the end of the presentation. So thank you, Liz and Deb. That was a really great presentation. And thank you, everybody, for joining today. You'll be able to find the recording for this webinar on our website in the coming weeks. We also encourage you to visit the Safer Prescribing Toolkit, where you can find evidence-based information on opioid prescribing and all sorts of topics. And coming soon, we'll have a specific toolkit on nursing and opioids that you can reference as well. Next slide. To claim CME, please scan the QR code that's right now on your screen. You'll also be able to find these instructions in the follow-up email that you'll receive shortly after the webinar. The follow-up email will also contain a survey about today's session. We really do read all of the comments and responses and greatly appreciate your feedback. It helps as we continue to develop these out and put out new topics. Next slide. And then finally, we hope that you can join our next session. It's about 2 weeks on the topic of stimulants, prescribing risks, and management. You can scan the QR code there to learn more and register, and more information will also be in that follow-up email as well. With that, thank you for attending. We hope to see you on August 20th.